80 million. That's the estimated number of Americans who are carrying right now, while watching this video, while breathing, while sleeping, a living fungus inside the tissue of their lungs. Not as an active infection, not as a declared disease, as a silent, encapsulated tenant, waiting for the right window, waiting for the moment when the immune system lowers its guard for whatever reason, a course of corticosteroids, chemotherapy, a transplant, undiagnosed HIV, simple aging to emerge from the capsule in which it was sleeping and begin to move. For most of these 80 million people, that moment will never come. For some, it has already begun, and they don't know it. It's called histoplasma capsulatum, and it didn't derive through the hospital. It didn't derive through contact with someone who was sick. It didn't derive through contaminated water or poorly prepared food. It arrived through the air. You inhaled it. Probably years ago. Maybe decades. On an ordinary afternoon, as you cleaned an attic, turned over soil in a garden, entered a chicken coop, explored a cave, or renovated an old house, the microscopic spores of histoplasma capsulatum hung suspended in that air, which seemed merely dusty. You breathed them in without feeling a thing. Your immune system found them, surrounded them, and encapsulated them in structures called granulomas, small fortresses of scar tissue that trapped the fungus without killing it. And there it stayed, alive, latent, intact inside your lung, waiting. The question isn't whether you were exposed. If you've lived in or visited any part of the Mississippi Valley or the Appalachians, the CDC's documented probability of exposure exceeds 80% of the population. The question is what happens when the fortress your body built begins to weaken. What CDC records reveal about exactly where histoplasma capsulatum is concentrated in the United States, and which completely mundane household activities produce the highest exposure load will change how you look at a simple home renovation, a garden, a basement. But the mechanism by which it escapes the capsule and begins to destroy tissue is the detail that most primary care physicians never learn to recognize in time. Daniel Mercer was 57 years old, a retired accountant from Louisville, Kentucky. No history of cancer, no autoimmune disease, no HIV. He had taken a course of prednisone, a common corticosteroid prescribed by his general practitioner for inflammation in his right knee. 40 days of medication, standard dosage, routine procedure. 3 weeks after the end of the prednisone course, Daniel went to the emergency room with a fever of 39.4 degrees Celsius, a persistent dry cough for 10 days, and fatigue that, in his words to the on-call physician, felt like someone had emptied my body from the inside. The on-call physician looked at the chest x-ray. He saw bilateral pulmonary infiltrates. He ordered broad-spectrum antibiotics for community-acquired bacterial pneumonia and planned discharge in 48 hours with outpatient follow-up. It was the diagnosis any reasonable physician would have made with that set of data, and it was the wrong diagnosis. There were 2 options at that moment. The first, treat it as bacterial pneumonia, wait for a clinical response in 48 hours, and, if the patient did not improve, reconsider the diagnosis later. The second, consider that a patient from Louisville, Kentucky, with recent corticosteroid-induced immunosuppression and pulmonary infiltrates that did not respond to the typical clinical pattern might be experiencing a reactivation of disseminated histoplasmosis, and order a urinary antigen test for histoplasma before starting any treatment. The on-call physician chose the first option. It was statistically defensible. It was protocol. It was what any physician would have done. And Daniel Mercer had, at that exact moment, a therapeutic window that itraconazole, the correct antifungal, could still cross with a real chance of complete reversal. 48 hours later, with no improvement with antibiotics, Daniel was in the ICU with progressive respiratory failure. Histoplasma capsulatum is not an exotic organism imported from a tropical rainforest. It is a native inhabitant of American soil, specifically the soil of the states along the Mississippi Valley and the Ohio River, where the temperature, humidity, and organic composition conditions create the perfect environment for its proliferation. Ohio, Indiana, Illinois, Kentucky, Tennessee, Missouri, Arkansas, Mississippi, Louisiana. This geographic range concentrates the highest documented density of histoplasma in the world. But the fungus has a specific biological accelerator, bird and bat droppings. The nitrogen in the droppings of pigeons, starlings, chickens, and bats creates exceptionally rich soil conditions for the reproduction of histoplasma capsulatum. Attics, roofs, chicken coops, barns, Old bridges, caves, any structure where birds or bats regularly inhabit accumulate spore concentrations orders of magnitude higher than the surrounding soil. In 2020, CDC researchers reviewed surveillance data and estimated that approximately 100,000 new cases of histoplasmosis occur annually in the United States, the overwhelming majority undiagnosed, classified as viral pneumonia, unresponsive bacterial pneumonia, or sarcoidosis. The CDC itself acknowledges that histoplasmosis is chronically underdiagnosed because its symptoms are clinically indistinguishable from more common pneumonias without specific testing. And the specific test, the urinary antigen for histoplasma, is not included in the standard diagnostic panel for pneumonia in any American emergency room protocol. To understand why progressive disseminated histoplasmosis has an 80% mortality rate without treatment, it is necessary to understand what histoplasma capsulatum does when the immune system loses the ability to keep it encapsulated, not in general terms, but sequentially, structure by structure. Histoplasma capsulatum is a dimorphic fungus, meaning that it exists in two distinct forms, depending on the temperature. In soil, at temperatures below 35 degrees Celsius, it exists as mycelium, a filamentous structure that produces spores called macroconidia and microconidia. When inhaled and heated to body temperature of 37 degrees Celsius, these spores convert into the yeast-like form, oval cells of 2 to 4 micrometers that are actively phagocytosed by pulmonary macrophages. And here is the mechanism that makes histoplasma extraordinarily dangerous. Unlike organisms that die when phagocytosed, histoplasma survives and reproduces inside macrophages. It inhibits the fusion of the phagosome with the lysosome, the process by which the macrophage normally digests, and destroys the pathogen, manipulating the internal pH of the immune cell to create an environment favorable to its own replication. In individuals with intact immunity, CD4 T lymphocytes organize a granulomatous response that traps infected macrophages in calcified structures. The fungus remains alive but contained. This is the latent state that 80 million Americans carry. When the CD4 count drops due to HIV, chemotherapy, corticosteroids, or post-transplant immunosuppression, the granulomatous response weakens. Existing granulomas begin to lose structural integrity, and the infected macrophages, now without adequate supervision from T lymphocytes, migrate. They leave the lungs. They enter the systemic circulation. They carry histoplasma to the liver, spleen, bone marrow, adrenal glands, and central nervous system. Progressive disseminated histoplasmosis is not pneumonia that is worsened. It is a systemic infection where the vehicle of dissemination is the host's own immune system. The cells that should destroy the fungus have become the transport by which it colonizes the entire body. In Daniel Mercer, prednisone had suppressed his T lymphocyte response long enough for the pulmonary granulomas that had formed decades earlier when he was young and working renovating old houses in Louisville to lose structural cohesion. The fungus that had been dormant for perhaps 30 years awoke within weeks. Dr. Chadi Hage, a pulmonologist specializing in fungal lung infections at Indiana University School of Medicine, published an analysis in the New England Journal of Medicine in 2015 that the American medical community received with the uncomfortable silence of those who recognize a problem they prefer not to quantify. Hage and her team reviewed 922 documented cases of histoplasmosis in American hospitals over 5 years, and found that the average time between the onset of symptoms and the correct diagnosis was 25 days. In cases of progressive disseminated histoplasmosis, this number rose to 32 days. And in patients who died before the correct diagnosis, a subgroup of 156 people in this analysis, the average time was 38 days of incorrect treatment before death. 38 days treating the wrong disease while histoplasma colonized the liver, spleen, and bone marrow. The most frequently documented reason for delayed diagnosis was consistent. Emergency room physicians and general practitioners did not include histoplasmosis in the differential diagnosis of atypical pneumonia because they did not associate the geographic risk with the patient in front of them. A patient from Louisville, Kentucky, a documented epicenter of the histoplasma epidemic in the United States, would arrive at the emergency room with bilateral pulmonary infiltrates, and the physician would not inquire about exposure to disturbed soil, attics, birds, or caves because this is not an item in the standard pneumonia assessment protocol. It is not an individual failure, it is a systemic protocol failure. And the consequence of this failure, documented in federal infectious disease mortality data, is that disseminated histoplasmosis kills approximately 3,400 Americans per year, most classified on death certificates as respiratory failure or sepsis of unidentified pulmonary origin. The detail that transforms histoplasmosis from an epidemiological curiosity into an immediate personal threat is the specificity of the exposure activities and how common they are. In 1978, in Mason City, Iowa, a single cleaning activity of an abandoned chicken coop exposed 339 people to Histoplasma capsulatum spores. 48 developed symptomatic histoplasmosis. The study, published by the CDC, documented the case as a definitive example of single-point exposure at a high concentration. In 2001, in Indianapolis, Indiana, the renovation of an urban park removal of old trees inhabited by starlings produced an outbreak with 523 confirmed cases of histoplasmosis. It was the largest documented urban outbreak in the United States up to that point. In 2021, cases of histoplasmosis were traced to an activity that no public health guideline had previously identified as a priority vector: inspection and cleaning of central air conditioning ducts in older homes in the Mississippi Belt, where bat droppings accumulated over decades inside the ducts became aerosolized when the system was turned on after renovations. Your home air conditioner, turned on after a summer of renovations. And the last high-risk exposure that 2023 data from the Infectious Diseases Society of America documented as emerging: buying and tilling soil for gardening and landscaping projects in endemic states, an activity that grew 34% in the United States between 2023, during and after the pandemic, when home gardening became the fastest-growing leisure activity among middle-aged American adults. The same demographic group that, due to age, is most likely to be using corticosteroids, post-transplant immunosuppressants, or cancer treatments. The same group that has a higher burden of dormant granulomas formed from previous exposures. The group with the least immunological reserve to keep the fungus encapsulated. The rheumatologist who prescribed prednisone to Daniel Mercer was treating real inflammation with the correct medication for that indication. Prednisone is a corticosteroid that suppresses the inflammatory response with documented efficacy and decades of safe use in millions of patients. No American clinical guideline requires screening for latent histoplasmosis before a course of corticosteroids in an immunocompetent patient with no history of fungal disease. No consent form for prednisone mentions the risk of reactivation of dormant histoplasmosis. No American electronic health record system has an automatic alert that connects corticosteroid prescriptions to residents in an endemic state for histoplasma. The instinct to relieve Daniel Mercer's knee pain created the window through which 30 years of dormant fungi emerged from their capsule and began to move through his body. It was not negligence. The rheumatologist followed protocol, the general practitioner followed protocol, the emergency room physician followed protocol. The problem is that the protocol was built without including a question that takes 30 seconds. Where have you lived? What have you done in the last 50 years? Have you ever renovated old houses? Have you ever cleaned attics? Have you ever removed debris from structures where birds lived? 30 seconds of anamnesis that do not exist in the standard American protocol for prescribing immunosuppressants. And in the absence of those 30 seconds, prednisone, the same molecule that reduced the inflammation in Daniel's knee in 72 hours, served as a trigger for an infection he had been carrying for decades without knowing it. The healing of the knee awakened the predator in the lung. What American medicine learned from Daniel Mercer, from the 3,400 annual deaths from disseminated histoplasmosis, and from the studies by Hage and the CDC, is that histoplasmosis is chronically underdiagnosed, that urinary antigen is the most sensitive test available, and that it should be included in the differential diagnosis of atypical pneumonia in patients from endemic states. This knowledge has existed in the medical literature since 2007. It does not exist in any mandatory American emergency room protocol to this day. Daniel Mercer survived. After 61 days of hospitalization, 22 on mechanical ventilation, 39 in pulmonary rehabilitation, he left the hospital with his respiratory capacity permanently reduced to 68% of the predictive value for his age and physical build. He can no longer climb 2 flights of stairs without stopping. He will not renovate anything else. The fungus that entered his lungs one afternoon at work in Louisville, when he was 26 years old and didn't know that the air he was breathing carried something, is still there. In stable granulomas now, monitored by CT scan every 6 months. alive, contained, waiting. The protocol existed. The question was never asked. The difference between exposure to Histoplasma capsulatum that remains dormant forever and one that destroys lung tissue and spreads to vital organs is not rare genetics or access to elite specialists. It's 3 pieces of information that anyone can have and use now. First, know your risk geography. If you live or have lived in Ohio, Indiana, Kentucky, Tennessee, Illinois, Missouri, Arkansas, Mississippi, or Louisiana, or if you have visited these regions frequently, you have a statistically high probability of having been exposed to Histoplasma capsulatum at some point in your life. This is not a diagnosis. It is context that you need to communicate to your doctor before any prescription of immunosuppressants, systemic corticosteroids, or chemotherapy. Second, before any procedure involving immunosuppression, corticosteroids for more than 2 weeks, immunosuppressants for transplantation, biological agents for rheumatoid arthritis or inflammatory diseases, chemotherapy, explicitly ask your doctor. Given that I live in an endemic region for Histoplasma, does it make sense to do the urinary antigen test before starting this treatment? The test costs less than $80. A positive result completely changes the immunosuppression safety protocol. Third, and most immediate, if you are going to renovate an attic, clean a chicken coop, remove soil from an old structure, work in a cave, or disturb significant amounts of soil in an endemic state, use an N95 respirator mask, not surgical. N95 with proper facial seal. Histoplasma capsulatum spores are between 2 and 5 micrometers, large enough to be retained by an N95 filter, and small enough to pass through any conventional surgical mask. Daniel Mercer didn't know that the dust he breathed while renovating houses in Louisville in the 1990s was carrying something that 30 years later would awaken inside his lungs. Now you know, and the difference between knowing and not knowing in this specific case is the difference between a 30-second question to your doctor and 61 days of mechanical ventilation. But Histoplasma capsulatum isn't the only fungus that the human immune system is keeping dormant inside you right now. In the next video, Cryptococcus neoformans, the fungus that lives in pigeon droppings in every major American city, crosses the blood-brain barrier and produces fungal meningitis with a 70% mortality rate without treatment, and is causing a silent epidemic in people who never imagined they were at risk. The city where you live may be the vector, and the pigeon in the park may be the reservoir.